to kick in. Okay, well, welcome everybody. We're really excited today for this great presentation. We've got Dr. Flanagan here. He's going to be talking about functional approach to motor neuron syndromes. So I'm just going to read a little bio about Dr. Flanagan. So it looks like he did his undergraduate at Montana State University. Go Bobcats. He also did his Doctor of Medicine at the University of Washington School of Medicine in Seattle, internship at Medical College of Wisconsin affiliated hospitals in Milwaukee, Wisconsin in internal medicine, and he did his residency at Medical College of Wisconsin affiliated hospitals in Milwaukee, Wisconsin in PM&R. It looks like he also has some history in teaching. He is also, it looks like I read about his hobbies and interests are during his free time, he enjoys learning karate, hiking, skiing, hunting, fishing, and a multitude of other activities that involve spending time in the Montana outdoors. Around home, he likes to spend time gardening, cooking, and spending time with his wife, daughter, and dog. So you are free to go ahead and start, Dr. Flanagan. Again, thank you so much for this. We're very excited.
All right, me too. Thank you. Thank you for the introduction. So I'm taking kind of a new approach to this topic. Any feedback would be appreciated, as I found this to be something where even in my specialty training, it was sort of delivered in a very piecemeal form. And over time, I was able to piece it together through reading and enough exposure to patients with different conditions. And kind of in my mind, I'm trying to develop a way that I can really, rather than breaking it down so much, combine it into one set of symptomatology, hence the term syndrome on the screen, and present it this way. And I have erred a bit on the side of keeping it rather general for the time being, which is something I would like some feedback about. My intention here is to present this in a way that really is sort of a broad strokes approach that can be very easily clinically applicable, rather than to have something that's excessively bogged down in detail or data. All right, so as far as what I want to accomplish with you here today, and physiology of motor neuron pathways, simply because that does develop a framework in which to understand these concepts. And this is really a topic that I think if you can understand just the basic anatomy and the pathology associated with which syndrome you're looking at, the rest of it really falls into place once you think about it that way. Want to just spend a minute differentiating between upper and motor neuron syndromes and what we mean by that. I'm going to spend a little bit of time on spasticity and contractures, and then I would like to delve into the topics of neurogenic bowel and bladder, which I think are really the point in which these syndromes take on an element of mysticism and confusion for many providers, and I'm hoping we can clear that up a bit today for you. So this is a busy slide. This is the basic rundown of the anatomy of a motor pathway as we understand it. And again, I'm very much generalizing here. I think the key things to understand are you have crossover of most of the motor pathways at the level of the medulla, and from there things travel down the lateral spinal cords into the anterior horns, where they synapse with lower motor neurons and go on to the extremities or torso or wherever they go to control motor function. Again, the reason I present this is just so I'm going to say, if you look at what's in the red box here, this is all what we would consider upper motor neurons. So this is everything from the cortex down to the anterior horn of the spinal cord, once you have that synapse, then of course you're now into lower motor neuron territory. And I just make note that once you're at that anterior spinal cord, that's where you can get a mixed syndrome. This will make a little more sense in a minute here as we break down what happens with motor neuron syndromes, and a very major classification syndrome or system here when we look at these syndromes. So we have some sort of motor neuron lesion. And depending on where that lesion exists in the nervous system depends on what sort of symptomatology you can expect to see from it. So when we look at those in the upper motor neuron pathways, being the cortex through the anterior horn of the spinal cord, that's going to cause an upper motor neuron syndrome. I know it's kind of uncanny how the names just match up on that. Therefore, once we are beyond the anterior horn of the spinal cord, we are looking at motor neuron syndrome, the lower nature, and we'll talk a little more about the causes of some of these. And then in some cases, you can have a mixture of both. So when we think about this, well, where does this come into our clinical practice? Where do we see these syndromes? So, we think about upper motor neuron syndromes. I mean, just some very everyday examples, by far not an exhaustive list here, but we think about things like strokes and tumors and MS and spinal cord injuries, cervical myelopathy, cerebral palsy, et cetera. And you could really put together a series of lectures just on the causes of this, but those are some examples. And then when we move on to the lowers, if you recall, once you are past the conus medullaris and the spinal cord down below the level of L2, you are now in the cauda equina, and all of that is lower motor neurons, so anything called cauda equina syndrome. The stuff we see very regularly, diabetic neuropathies or peripheral neuropathies of other cause, Guillain-Barré, plexopathies, whether traumatic, metabolic, or otherwise, hereditary neuropathies. And then I would say in terms of identifying syndromes, we would also include problems going on at the neuromuscular junction. And that's going to make a little more sense here in a minute, but we do include those in lower motor neuron pathology. And then, of course, we've mentioned the mixed motor neuron syndrome, which isn't something we see as often. And of course, you could see this in a patient with multiple lesions, both to the upper and lower motor neurons. Classic example is you have a diabetic patient with neuropathy in the legs, and they may have some weakness from that. And then, of course, they're at high risk for a stroke. And so now you get a mixed syndrome once they've had that stroke and start developing an upper motor neuron syndrome superimposed on the neuropathy. Conus medullaris injuries, because there again you are looking at that level in the spinal cord where you have a mixture of both types of the motor neurons. Not a real common injury to see, but once in a while we do see this. And then motor neuron syndromes, things like amyotrophic lateral sclerosis and its variants. As far as signs and symptoms, this is where you start teasing it out clinically in terms of the signs and symptoms. And so in either case, we see weakness and paralysis. We know that whether a patient has Guillain-Barré syndrome or a spinal cord injury, let's say, that in either case, you're going to see weakness and paralysis. And so this is the point where we have to move beyond just that to really identify how we're going to identify a lesion and manage the syndrome from there. So starting with the upper motor neuron lesions, of course, we see things like hyperreflexia, spasticity, or we would term neurogenic dystonia, being abnormal muscle tone from a lesion in the brain or spinal cord. Clonus, these things that we tend to see in our patients with things like strokes, brain injuries, spinal cord injuries, cerebral palsy. And then we contrast that with what we would see in a lower motor neuron lesion, And I guess kind of the good prototype comparison would be, a true spinal cord injury versus like a cauda equina syndrome, where the first list of symptoms would be, say if we had a complete or near complete spinal cord injury at the thoracic level, versus a cauda equina syndrome would be your second column. And here we still see, yeah, you have weakness and paralysis, but now everything is just sort of, as I put it, loose and floppy. So we have hypotonia, we have decreased reflexes, but the weakness and paralysis still exist. Now, at the bottom of both of these lists, you noticed that I have neurogenic bowel and bladder syndromes, and I am differentiating between upper motor neuron and lower motor neuron neurogenic bowel and bladder, and we're going to go more into those differences and what that means. But these are components of these syndromes that often really get kind of lumped into one big category of neurogenic bowel or bladder. So we're going to talk about how the differentiating these between upper and lower really helps define how we're going to approach them clinically. And then, of course, in a mixed, we get a mixture of both, as one would expect. Just a quick plug on mixed motor neuron syndromes. If you have a patient come in with a new unexplained constellation of motor neuron findings that are upper and lower without a good explanation, the first thing you want to think of is ALS until proven otherwise. Again, reviewing that anatomy, and that we are probably looking at something occurring in the anterior horn of the spinal cord, which does occur in those conditions. So that will prompt, or should prompt, a referral to neurology pretty quickly. So back to the topic at hand here. I want to start out with talking about what happens in upper motor neuron syndrome in terms of how this can affect mobility. And one of the things we often see patients for in PM&R is the symptom of spasticity. This is where I want to start going into a little more detail, in definition here. Spasticity, by definition, should meet some certain criteria. This is an involuntary contraction of skeletal muscle. And if you look at the diagram to the right, which we all saw sometime back in medical school or PA school or whatever our relative training was, is that under normal conditions, we have stretch reflexes, and we all know that if you tap on a quadriceps ligament, that you get an immediate contraction of the quadriceps itself, and you get relaxation of the hamstrings. And this is mediated through an interneuron in the spinal cord, which is labeled as number 6 here, the small green connection in the middle of the spinal cord. The purpose of that interneuron is to shut things down until it's appropriate to have it on. Now, what happens, and isn't displayed here though, is that with lesions in the upper motor neuron pathways, you get loss of a mechanism called descending inhibition, which is basically that our brains will tell our bodies to relax until we don't want it relaxing. So you can sit there and relax right now. Your arms and legs are not contracting, but if you go to get up out of the chair, you can tell them to do that. So what happens in spasticity is, due to a lesion in those motor neuron pathways, you shut down that inhibitory signal, and now you get this override of this uncontrolled reflex that just tells the muscle to fire constantly. And so you get a very, very low threshold for muscle firing, sometimes so low that it just doesn't even stop firing. And then we describe this as being velocity dependent. So what does that mean? What this means is that, say for instance, if I am examining a patient with spasticity of an upper motor neuron nature in my clinic, and this is going on in the patient's elbow flexors, i.e. biceps, if I range that slowly through extension, I might be able to get full range of motion, but if I return it back to a flex position and I pull it quickly, now I get a catch or the muscle contracts. So that's what's meant by velocity dependent. And I want to put in a plug here for spasticity versus contracture, because it's something where I just see the language used interchangeably, and something where I often get referrals for spasticity that sometimes are confused with contracture. So I just defined spasticity for you. And again, this is involuntary muscle contraction. When we look at contracture, what we're looking at is a fixed or limited position of the joint due to rheologic changes of the soft tissue, which basically means if you take any joint and you fix it into a certain position for a certain amount of time, the soft tissues around that joint are going to remodel, and it is going to be difficult or impossible to move the joint out of that position after a while. And that can be from casting. Certainly spasticity can lead to that over time if uncontrolled. It can be from just a number of things that hold the joint in a certain position, and we often see things like even in patients for whatever reason who spend a long time in wheelchairs and they're not dorsiflexing their ankles, they develop these plantar flexion contractures. Prevention is key to this. So these are, if patients have an early neurologic injury or other injury for that matter, this is why we really emphasize the need for frequent range of motion. Once it happens, treatment is very difficult. There are some cases where you can do things like serial casting, but often you're looking at a surgical approach to treat contracture. And clinically, you can identify this more by just a firm endpoint at the range of motion rather than, like I said earlier, with spasticity, where if you keep tension on it long enough, it will move. With contracture, it just won't. So a few slides on the treatment of spasticity, and I'm not going to dwell on this too much other than to say that we are here to help. We all know about baclofen, of course. That's a GABA agonist. Alpha-2 agonists such as tizanidine and clonidine are frequently used. Benzodiazepines work very well, but of course come with their own set of side effects and adverse effects and risks. One we often don't think about are the anti-epileptics like the gabapentinoids, which can really make a pretty decent adjunct to treatment. And then one we don't use too often and should probably use a little more is dantrolene. So we look at these. I'm sorry, this is kind of a busy slide, but I just wanted to give you a comparison on these treatments. So when you look at the benefits / pro column, really that describes the majority of that list is what we're trying to accomplish with any treatment for spasticity. And then, of course, with the number of these medications, the biggest thing we're looking at in adverse reactions is weakness, altered mental status, drowsiness, dizziness can occur, bowel and bladder problems, hypotension. And so these all come with sort of their own common package of side effects. When you look at dantrolene, this can be a good alternative in some cases because it spares the cognitive function. However, the big risk with that is that it can cause very severe and fulminant liver failure, so you have to be really careful to monitor the liver functions while you're using that. Onto the stuff that people want to hear a little more about typically. So botulinum toxin injections, of course, the one we use the most is Botox, and these work by blocking the vesicular release of acetylcholine at the neuromuscular junction. So if you recall back to your A&P education, you have the axon terminal with vesicles of neurotransmitters in them, and certain pathways happen that cause those vesicles to fuse with the membrane at the terminus of the axon, and that releases into the synaptic cleft, goes to the muscle cell and activates at the sarcoplasmic reticulum, causing muscle contraction. And this essentially binds to a protein called SNAP5, which is involved in that fusion process, keeps the acetylcholine from being released, and then therefore you decrease the muscle contraction and improve the spasticity situation. In addition to what we've already discussed on the benefits of spasticity management, again, one of the big benefits of this is the sparing of mental status as opposed to systemic medications. You can target it very well. It has a good local effect. So if a patient doesn't have widespread spasticity, if it's isolated to one or two limbs or muscle groups, you can target those very well. You can also target it very well in terms of improving effectiveness of the antagonist muscles. The big parts or the big side effects or adverse effects can be weakness. It does wear off, and you can generally restore that. But it requires a lot of specialized training, special equipment, EMG guidance, or ultrasound guidance. It's not a comfortable procedure. You got to understand when you refer someone for Botox, this is it's a lot of injections in one sitting to even have a pretty basic Botox procedure done. And sometimes I might inject people 30 times or more in one sitting. And it does wear off. We can inject up to every 3 months, but typically people start noticing it wearing off a little sooner, sometimes a little later. Selective nerve blocks are an option at times. We use phenol or ethanol to do this. It creates a lesion in the motor nerve and blocks the nerve going to a specific muscle. This is something I personally don't do a lot of. I've done some in musculocutaneous nerves and obturator nerves. Some providers do more of them. It can be a good option. The big risk with this is that the nerve repairs itself. And so as much as you would think that, doing a chemical burn on a nerve would cause lasting effects, typically it does wear off over some time. And in some cases, people can get a rebound spasticity based on how that nerve remodels over time. And sometimes that rebound spasticity can be worse than the original, so it's a significant risk. Motor point blocks are just where we just inject some local anesthetic directly into the muscle to block the small peripheral branches at the motor units. And the problem with this is, like any other local anesthetic block, it wears off in several hours. And so therefore it's very limited. I would say the real utility I've had with this is sometimes on inpatient rehabilitation, I can do a couple of these during the stay and have physical therapy, really get a good stretch in during the rehabilitation process. And anecdotally, that seems to maybe help sometimes in the long run. And then the other thing it can be useful for is differentiating spasticity from contracture. If there's kind of a gray area there, you can relax the muscle long enough to get a good stretch and get to the end of range of motion and see what's what. Intrathecal baclofen therapy is it's one of my particular areas of interest. This is where we use specialized surgically implanted equipment that delivers baclofen directly to the intrathecal space, basically right at the spinal cord. And so very cool technology, tends to work very well for a lot of patients that otherwise have refractory spasticity, widespread severe spasticity, or just don't tolerate other treatments. The big benefit of this is that you can titrate with microdoses into a very narrow therapeutic window, meaning that you can achieve good effect without having adverse reactions by just being able to do real little changes in microdoses to get an effect. That's really the big advantage. We can program these in boluses. We can have them running continuous. We can set up timing of boluses. There are a lot of pretty neat tricks we can do with it. Often we can eliminate the need for oral medications. It does definitely cover a lot more territory than Botox, although tends to work much better for lower extremities than upper extremities. We can combine it with other procedures if needed, so sometimes it's enough to give you enough effect that you do the Botox and now it works much better, or the oral medications work much better with it. Obviously, the big risk or the big risk or adverse effects with this come with the need for requirement of surgery and having foreign body, risk of infections, etc. And there is a very significant risk of overdose or withdrawal syndromes if you have malfunction of the equipment, which can actually be life-threatening. So requires very good monitoring. You have to have very compliant patients and families to do it.
Hey, Dr. Flanagan, there is
Yes.
one question in the chat
Sure.
related to baclofen. It says, it's from Shane, and it says, do you ever use baclofen above recommended max daily dose of 80 milligrams for spasticity? Wow, I can't say that word today. 120 milligrams daily is his question.
Have I ever? Yes. Do I ever? I try not to anymore. Again, you start getting into the adverse effects. And honestly, I think by the time, if I'm getting up to 80 milligrams of baclofen a day, maybe I've added on another second agent, and I might put on an alpha blocker, dantrolene or something like that. If I'm not getting good effect on a couple of oral medications like that, in most cases, I'm looking at starting other treatments, injection therapy, or talking about a pump if the patient's appropriate. Does that answer the question?
Yeah, that's great. Thank you.
I'm going to switch gears now to the effects of the motor syndromes on bladder. So neurogenic bladder, just looking at very basic anatomy here, we divide this into upper and lower tracts. That's about as far as I'm going to go into the specifics of this anatomy for our purposes today. I will note that when you look at the lower urinary tract, you're looking at the majority of the bladder itself, including the muscular wall with the detrusor function, as well as an internal and external urinary sphincter. So the important part I want to emphasize about neurogenic bladder is the ureterovesicular junctions. And so this is kind of the key anatomical structure of importance when we think about these syndromes. So these junctions act as one-way valves in the bladder, and what do? They prevent reflux of urine back up into the ureters and kidneys. But they are a functional valve. They are not an anatomic valve, say like an actual muscular sphincter. They require a certain structure in that area of the bladder. So therefore, if you overstretch them or you overcontract the bladder, the valve function becomes compromised. And so these syndromes do put patients at risk for reflux of urine. So my approach to neurogenic bowel and bladder is I say think about what's happening in the limb given this patient's underlying neurologic diagnosis. So if I can think, I think this patient has neurogenic bowel or bladder, what happens in the ankle on this patient, or what would I expect to happen? I.e., if the patient has had a brain injury or a stroke, I'm going to expect things like clonus and spasticity, dystonia in the ankle. And therefore, I expect a similar pattern with these other mechanisms. Likewise, if it's of a lower nature, severe neuropathy, Guillain-Barré syndrome, Cauda-Equina syndrome, I'm thinking of something more of a very hypotonic or atonic nature. So bladder function overall, the important thing when we're thinking about these syndromes and management of neurogenic bladder is, again, that stretch reflex at S2 through S4, where our brains can typically override that, and that signal can become interrupted. And so if you think about the bladder wall, muscular wall with the detrusor muscle in there, I know it's not the same as skeletal muscle, but there is a stretch reflex that is active in that mechanism, so that normally once our bladders get distended enough, and it's time to appropriately void, we are able to coordinate relaxation of the sphincter muscles in the outflow tract, and simultaneously the detrusor squeezes down on the bladder. And part of that is driven by a reflex. So what happens when you have an upper motor neuron lesion is you get a spastic overactive detrusor muscle. It becomes uncoordinated, it's hyperactive, it spasms, and because of that, you often see low volume incontinence. In other words, as you get these little spasms in the bladder, it just squirts out a little bit of urine at a time. Plus, it can be painful in the genitals a lot of the time and uncomfortable for the patient. And then because of structural changes in the bladder itself, you then compromise those uretrovesicular valves, and you get reflux of urine. And we'll talk a little bit more about some of those consequences. So how do we treat this? I think of it as though you're trying to accomplish the opposite of what's going on given this pathology, right? Same as we do with most of our medical treatments. So we want to relax the detrusor, and for this, we think of, well, that is like most visceral functions, that is a cholinergic driven mechanism, and so we give anticholinergics, and so this is the appropriate use of oxybutynin, known as ditropan, or a similar anticholinergic medication, or something that's going to relax the bladder. In the meantime, we want to relax the sphincters, and for these we use what we use for outflow obstruction, alpha-1 blockers like tamsulosin, same as you would use for prostate disease. The idea is you want to dilate the outflow tract while relaxing the bladder to a certain extent that you don't have this uncontrolled stretch reflex that is just causing the bladder to go crazy and cause this low volume incontinence. And then, of course, often we just have to use mechanical devices, different types of catheters to drain the bladder if we can't achieve that with medication. Now, we switch gears to a lower motor neuron lesion. Here, just like at the ankle, we're expecting hypotonic, floppy. The bladder becomes enlarged. This is often where we can really see very distended bladders, even up to holding a couple liters at a time. And then you start seeing a pattern of overflow incontinence with urinary retention. And again, you stretch the bladder out and you get compromise of those valves, causing reflux. When we think about treatment for this, of course, again, we want to do the opposite. Now we want the bladder to contract. Botanicol or urocholine is a medication that is used by some. I don't have great success for it, but it's worth a try in appropriate patients. The big one here is you want to get the sphincters relaxed. So I use a lot of alpha-1 blockade in these patients to see if we can establish a better urine flow. These are, if they're patients in the hospital, say you get a new diagnosis of cauda equina or Guillain-Barré, something like that, these are the ones you want to be watching those urine volumes very carefully. Very importantly with these patients is they may void what appear to be normal volumes on their own, say, for 400 cc, somewhere around there on their own, and it's important to understand they may still have that or way more left in the bladder. So if you're doing kind of the acute workup on the urinary tract in these patients, really important to get the bladder scans and follow that closely. And again, sometimes you just have to drain mechanically. And of course, if you have this valve compromise, you get reflux. Over time can lead to hydronephrosis. You get carriage of renal stone forming bacteria into the kidneys. And of course, you can actually get infection in the kidneys in certain cases. And for this reason, it's even recommended that the patients we follow chronically for spinal cord injury get annual surveillance with renal imaging to evaluate for stones or hydronephrosis. So let's talk for a minute about neurogenic bladder and urinary tract infections, because this is a problem area. This is something, if any of you take care of patients with chronic spinal cord injuries, you know the heartache and frustration that goes into trying to figure out what to do with the microbiological data in these patients. And it's a very important place where if you can understand what happens in the bladder, it helps you understand how to approach this. So Again, upper motor neuron lesion, you have the increased detrusor tone, increased pressures in the bladder over time cause thickening of the bladder wall. It becomes hypertrophic. And with that, you get diverticulae and trabeculations in the bladder wall, causing all kinds of nooks and crannies, which are just great little places for bacteria to set up shop and live. So bacterial colonization is very common in patients with chronic upper motor neuron syndrome, and you look at microbiologic data such as that, as I have pasted all over the screen here. And in fact, this was in a patient from residency with spastic quadriplegia from a traumatic spinal cord injury, who had been in the hospital multiple times. And all of this data came in within the course of about 8 months with subsequent visits. And if you look at it, these are not the same bugs over and over. This is not the same thing over and over. And if you look at it, you're probably just wondering, where do I even start in trying to treat this patient for a UTI? Very general approach here. The goal is not to eradicate every colony in the urine. I say, you look for the troublemaker. I get the culture because I think it's useful to have the data. But if I get that culture and I see, 100,000 CFUs of E. coli or Klebsiella in there, hey, that's pretty suspicious for our cause. That's what we see all the time with UTIs. Go after those things. Go after those, monitor the patient, see how they do, and you can broaden out later. But I've seen so many cases where these patients just get hit with broad spectrum IV antibiotics. And then, of course, over the course of a couple of years, they start coming in with mini bugs that are resistant to even the big guns. So one of our big goals in these patients is to avoid breeding drug resistance. And you just, you have to gauge it clinically. How stable is the patient? Is it something I could start with some maybe some Bactrim in the outpatient setting and call them in a couple days and see how they're doing? Obviously, if it's somebody who shows up in the ER with sepsis, we do what we have to do. But the end goal is not to get rid of all the bacteria, because if you culture them out again in a few months, you're going to start seeing some things pop up there again. You can chase your tail endlessly doing so. And in the meantime, probably not really going after the bacteria that's causing the patient to be sick. Shifting to neurogenic bowel, again, looking at stretch reflex at S2 through S4 levels in the spine. Very similar principle to what we just described with bladder. You have an upper motor neuron lesion, you get a spastic discoordinated bowel that's not good at peristalsis anymore. You have a spastic pelvic floor, including the anal sphincter. This slows transit time in the colon, where the majority of water is extracted out of stool. This leads to hard, dry stools, can lead to obstipation. It can be very difficult to get going once it is, once you're behind the 8 ball on this. And so it's better to keep it going rather than to try to get it going. A lot of these patients will have very specific bowel programs in place that they can describe to you better than I can, because they've been doing them, particularly in the spinal cord population. But anyway, the treatment for this, kind of the same approach. You want to sort of reverse what's going on there. So if you have a spastic discoordinated bowel, we want to trigger the stretch reflex, which will actually promote peristalsis. Medically, in terms of pharmacologic management, we think of things like bisacodyl, sinusoids as the bowel irritants, which tend to be better for this. And digital stimulation can do that as well, where we teach the finger or the patient or caregiver to place a finger in the rectum and stimulate manually, and that can actually stimulate peristalsis and get the bowels to move. At the same time, you want to keep the stool a reasonable consistency, so that, if you think it's having to be pushed through a spastic outlet, that you want that to be of a softer consistency. And so we're going to use things like Miralax and Colace for that. Quite the opposite when we think of lower motor neuron lesion, and this is the part where I often see things go bad. with the lumping together of all syndromes as being neurogenic bowel is lower motor neuron neurogenic bowel is very difficult. You've got this hypotonic bowel, again, doesn't want to peristalse or do much, tends to become distended. Plus, you now have decreased sphincter tone in the outlet, and this can be accompanied by constipation, diarrhea, incontinence, a number of things. This becomes very difficult, and the number one thing I want to drive home on this is please be very careful with stool softeners. Again, here you are dealing with a flaccid anal sphincter, and if you start softening stool, you can ruin someone's life pretty quickly. You know, I've seen cases of this where you know, under well-meaning, this has been done inadvertently, and you know, patients will end up in nursing homes because they now require chronic wound care, things of that nature. So please be careful with the stool softeners in these patients. Not that you can't use them, but you're not going to approach it with the same level of aggressive therapy that you would for somebody, say, an actual spinal cord injury or an upper motor neuron syndrome. Sometimes these patients need to run the stools on the harder side actually and do manual removal as well. And sometimes that's what ends up working best. So just to summarize all of it, you know, upper and lower motor neuron syndromes, very different in appearance and approach to treatment. We've explored a number of reasons why. Spasticity is only related to upper motor neuron syndrome. And I want to emphasize this a little bit because I do get a fair number of referrals for evaluations for Botox injections, say like in patients who've had orthopedic procedures and are now contracted in an ankle or a knee, asking if Botox would help. And, you know, the answer inevitably becomes, no, I don't think so, because this is not of a upper motor neuron etiology, and it's not going to treat the remodeling of the soft tissues around the joint. Contracture are completely different from spasticity, as we just discussed. Neurogenic bowel and bladder management depend on upper versus lower motor neuron etiology. The things we talked about with urinary tract infections and motor neuron syndromes take special considerations. Again, if you can think about what's happening anatomically and how those structures are becoming altered based on the nature of the syndrome, then that's really going to help guide you in terms of understanding what's going on, what are the risks of the treatments you're considering. And I'll leave that at that. And that's my dog. Any questions?
Love that picture, Dr. Flanagan. That's great. And a really beautiful view in the background as well. Thank you so much for the presentation. I just wanted to, before everyone took off, I know we've kind of got a hard stop at 1 o'clock. Just a reminder that the Primary Care Symposium is this Friday, May 14th, and registration is still open for that. And I did put the information in the chat for you. If you need me to send that out to you, I certainly will. Again, my name is Jennifer Leninger, and I can certainly send that to you. So it's just jleninger@billingsclinic.org. So I just wanted to, again, thank you so much, Dr. Flanagan, for a wonderful presentation. And I hope everyone has a great rest of their day.
Thank you.
I'd like to thank you. This is Jeannie from RiverStone. Sorry I wasn't available for the introduction, but that was a great presentation on motor neuron syndromes and the treatments. And I would remind everyone at RiverStone to please complete the evaluation if you're interested in CME credit. Thanks a lot for your presentation.
Thank you.
Thanks, Jeannie.